Hello, everyone. My name is Tom Pansella with the Missouri Institute of Mental Health. Thanks for taking the time to be with us for today's program on suicide prevention with Scott Perkins. I'll introduce Scott to you in just a moment. For those of you who are interested in asking questions anytime during today's presentation, use the email question for speaker link underneath the video or audio window there. That'll send us an email with your question, and we'll ask them on your behalf at the end of the presentation. If you are interested in CEUs, there is a link for a CEU application also underneath the speaker's video window there. And there is a link to the PDF for the slides. If you'd like to scroll through the slides on your own, we'll also send them to you in the follow-up email following today's program. And so I'd like to introduce Scott Perkins, who earned his MSW with a concentration in policy, planning, and administration from the University of Missouri-Columbia. He's certified as a crisis worker from the American Association of Suicidology and is a certified instructor of several suicide prevention programs. In his role as a project director here at the Missouri Institute of Mental Health, he oversees the implementation of the Missouri Youth Suicide Prevention Project. And Scott, thanks for joining us, and the floor is yours.
Thank you. Good afternoon. Let me see. I'd like to start off this afternoon by showing you a few brief slides on some of the statistics that have been released recently regarding suicide, mostly in Missouri, but also a little bit on national statistics. This is the national rankings for 2006, which is actually the most recent year available at the national level, and these just came out, I think, over the summer. It shows Missouri tied in 17th place with Kansas. And that was, in 2006, Missouri had a suicide rate of 13.7 compared to the national rate of 11.1. And so historically, Missouri has had a higher suicide rate than the national average. But we've seen usually as it goes up or down from year to year in the national level, it does the same thing. In Missouri, it's a little bit more dramatic maybe in some of these years. But and you'll notice that for the past 2 years, we don't have the national level ends at 2006. We saw a spike that year in Missouri, and then it's gone kind of evened out and then went back down in 2008. So in 2008, there were 775 suicides in Missouri, which is an average of one suicide every 11 hours and 20 minutes, or roughly 2 completed suicides per day. This is a chart of the leading causes of death in Missouri. This was released by the Department of Health and Senior Services in Missouri just last month in their Vital Statistics annual report. It shows suicide as the 11th leading cause of death. In 2007, it was the 10th leading cause. It's usually one or the other, probably the 11th leading cause most often. And it's also the 11th leading cause nationally. And so while it is one of the leading causes of death, it's also a relatively rare occurrence, especially in some of the rural areas. In some counties, I looked at last year, actually a majority of counties in the state, there were 4 or fewer suicides, with a handful of not having any suicides at all during the year, which makes it difficult sometimes to get accurate statistics regarding the rate in those rural areas. This shows just the top 5 leading causes of death in the state, and you'll see. Let me see. I guess the 5 to 14 age group. Actually, last year it was the 4th leading cause, and these are pretty small numbers: homicide and suicide, 7 and 6 deaths. But it's moved down to the 5th leading cause, and then I think the age group 25 to 34 was the 2nd leading cause of death the year before, and in 2008 it's gone down to the 3rd leading cause of death. There's a few different ways, or lots of different ways, I guess, to look at the statistics. This right here kind of shows you both the number of suicides and the rates of suicide in the state by age group. So you can see the blue marks down here have the total number of actual deaths. So the 45 to 54-year-old age group has the highest actual number of suicides, and actually also the highest rate of suicide. And then it goes down and dips, goes back up. The rate itself goes back up in the later years. I usually throw this slide in presentations, and I know a lot of people have seen the iceberg slide, but I just think it's really good for suicide prevention, because if you look at just the completed number of suicides, I think you're only seeing part of the whole picture, you're missing out on a lot. Not only the number of attempts of suicide, so the non-fatal attempts, but there's like a lot of the reasons and the stuff going on in the background, what would lead somebody up to suicide. So if this is just the actual number of suicides, there's a lot of other stuff down here. I'm going to try to cover a little bit of that this afternoon. Speaking of attempts, this right here shows in 2006 the rate of hospitalized attempts and the rate of suicide. And you'll see in the blue line, the 15 to 19-year-old age group actually had the highest rate of hospitalized attempts. And so those are only the people that appear, in the emergency room after an attempt. And honestly, some of these might not be a suicide attempt itself. It's an actual accidental self-inflicted injury. But only it's been roughly estimated that about 1 of every 4 suicide attempts end up in the emergency room. And then there's actually some other estimates. So it's estimated that there's far many attempts other than what this shows. But what I like about this is that it shows that the 15 and 19-year-old age group has the highest rate of attempts, and so if youth, some people ask why would you bother kind of focusing on youth if they have a lower rate of actual completed suicides. But I think this shows is a good example of that, because once you have an attempt, you're at risk, greater risk for suicide throughout your life. So I think if you can stop that first attempt early on, it'll kind of give them a protective factor throughout their life. And some of the other factors that involved in suicide attempts is the medical cost. Not often thought about, but it shows there nearly $9,000 for a hospitalized attempt and nearly $4,000 for suicide. Because a lot of times they find somebody after they attempted, and they do try to save themselves. And then there's the work loss. If it's one of the breadwinners for the family, a parent, there's a considerable financial aspect involved too. And then actually, some of my colleagues here at MIMH are involved in the Missouri Student Survey, which is done every other year. And it was done the spring of 2008, and this shows grades 6 through 12, nearly 15% of students had seriously considered attempting suicide, nearly 11% had made a suicide plan, 6% had attempted suicide, and of those, over 11% had an attempt that was serious enough to require medical attention. And actually, if you break it down by gender, this shows you kind of the same thing, divided up by male, female. Females have the higher rate of ideation plans and attempts. And what this breaks it down by grade level and gender, and it shows that females actually in 9th grade and 8th grade as well have the highest rate or higher rate of self-reported thoughts of suicide, which is over 20% there for the 9th grade females. So I'll talk a little bit today about some of the risk factors for suicide. There's some of these would probably be pretty obvious, but mental health issues, alcohol or drug abuse, hopelessness is a big one. I think comes up in most suicide attempts. Impulsive or aggressive tendencies, trauma or abuse in the past, physical illness, previous attempts, and family history. And then environmental risk factors would be, I think, any type of loss, whether it's a relationship, job, loss of their savings in the market, home, loss of independence, of their freedom, somebody that's maybe going to jail, going to prison, or independence if they're going to be moved out of their home into a nursing home, something like that. And then also access to lethal means, of course, is another major piece. Here recently, there's been a lot of news stories. You've probably seen some of them where they talk about suicide and somebody who had just lost, with the economy, somebody lost their job or something like that, and it kind of makes it sound like suicide is the only reason or the main reason that happened. But the fact is, a lot of people are in that same situation, do not attempt suicide. Most people do not consider suicide or attempted. So that's not that makes a good story, but it's not actually true. So there's been several national organizations over the past year or so that have released statements, and this is actually from the Suicide Prevention Resource Center. States, the unemployment in general is bad overall for your general health, and it can be a factor to suicide risk, but it does not cause suicide by itself. It causes financial strain and can lead to depression, which is one of the factors in suicide. So when we can expect a sharp downturn in the economy to increase the suicide risk overall. And let me see a few more risk factors for suicide. Isolation, stigma is a big one. There's still a lot of people that either they don't want to go to get help, admit that they're thinking of suicide, admit that there's that they're depressed. There's treatment for depression, but yet they don't want to think that other people think that they need help. And you see this more often in some different, like the military, for instance. People don't want to admit that they need help, or that it might hurt their long-term career, and so they avoid going to get help. And they've done a lot in the past few years to try to change that in the military and for veterans. Something that doesn't get as much attention, I think, as sometimes there's focuses on risk factors, but protective factors are just as important, if not more so. Just having access to care, whether it's for physical health, mental health, substance abuse disorders, is a big help. And some of these are pretty much opposite of the risk factors. For instance, the lethal means, having restricted access to lethal means is a major protective factor as well. And I have probably more slides than I probably should, so I'm going to try to skim through some of these, but they're online for anybody that wants to access them later. This is just kind of a quick overview of protective factors, and something that some of these you might not have thought about. For instance, pets. A lot of times people think, why would pets be on there? But if people, sometimes the pet might be the only thing that keeps them going. If they have a cat or dog that they're taking care of, and they'll be afraid that if they weren't around, what would happen to the pet? And so if suddenly the pet dies, or if they're suddenly wanting to give away a pet that they've had for many years, that could be a clue. And this slide right here just shows that there's multiple factors that go into suicide. So there's never just one thing that causes it. There's lots of things that line up, and some of these things could trigger the suicide attempt itself, but there's all these different factors that kind of play into it. And that previous slide with the wall of resistance, that right there is where you can prevent suicide. Something I wanted to talk a little bit about is the National Violent Death Reporting System, because most of the information that we have about suicide comes from the death certificate, which tells us limited information: gender, age, race. Sometimes it'll have veteran status on there. That's not always listed. So that's very limited information. Something that began, I think, in 2002 was CDC started working on the National Violent Death Reporting System. I think there's 17 states that are involved in that currently. And what they do is they work to bring information from multiple areas to put it together to really look at violent deaths. And suicide is the number one violent death. That's above homicide, which we always hear a lot about in the news about homicides, but there's more suicides than homicides.
Is Missouri one of those 17 states?
Unfortunately, it is not. And that's actually on this next slide. It lists the 16 of those. For a few years, they weren't funding any new states. They started, I think they put out a grant announcement recently on those. And their goal, I know, ultimately is to fund all 50 states. And it's, I think it would be just temporary funding to get states up and going. There might be some states that are involved in the reporting system that are not federally funded. But unfortunately, I don't think at this point Missouri would be able to do that without the grant. But I'm hoping that Missouri will have the opportunity to apply for that in the future. That it would be some great information, because the next few slides will show some information that was taken from the 16 states that are involved, that were involved from 2005 to 2007, and there was about 26,500 total suicides that they looked at. And so those grants, or those 16 states, weren't selected to represent the nation, so you can't really say that this would apply to Missouri, but there are a few, I think Kentucky and Oklahoma, there's some few surrounding states that were included in that report. And I think this is great information because it looks at stuff from the police report, from the coroner's report, other factors that were involved in that person's life when they attempted suicide. So you have the top one, current depressed mood is 44%. Current mental health problem, just like right below that. But you also notice that only 34% say that they're currently getting treatment for mental health or mental illness. So there's certainly this can provide some information that would be able to help prevent deaths. And some states have used this to kind of tailor what their efforts are going to be to prevent suicide or homicide. And something else, like this history of suicide attempts, 20%. So even though people that attempt are at a higher risk throughout the rest of their life, majority of people that die by suicide, that's their first attempt. So you don't have multiple times to try to step in and stop them. What's also interesting, you can look this up on the CDC website and look at different age groups or years and different topics. If you look at physical health, it's 22% overall, but I think if you look at the 65 and older age group, it jumps up to over 60%. So physical health becomes certainly a major issue when you're looking at older Americans. And then it kind of goes, this second slide kind of shows you a few more issues. And so there are financial problems, job problems come up. Relationship problem, even though it's only 11%, that is a major thing to look for. And like so, once again, if you look this up on the internet, the CDC website has actually lots of other information. You can look at status for place of injury. About 3/4 of the people that die by suicide die at home. But you can look up other information: pregnancy status, homeless status, military status. So that'd be some great information to have for Missouri. So once again, it would be great to eventually get that here. Real quick, I wanted to kind of talk about what to do if you think somebody might be suicidal. And actually, some of this information is available on the National Lifeline has some handy wallet cards, and there's a few different versions. One general one with a list of warning signs on there, and there's one specifically for counselors. And those are available free online. And let's see, that's suicidepreventionlifeline.org. They can order those. You can actually download them and print them for yourself, or order them free copies. They have magnets and posters and lots of different materials available. So even though you can't predict death by suicide, you can identify people who might be at increased risk, and it's probably impossible to stop every suicide, but I think it's one of the most preventable forms of death there is. And the easiest thing to do if you're concerned about somebody is just to ask them, directly, are you thinking about suicide? A lot of times people think that if you ask somebody that might put the thought into their head, which is entirely not the case. And a lot of times people might be given clues themselves about what they're thinking or what they're wanting to do, but they've kind of got blinders on. They might think they're being very obvious in what they're talking about, but in actuality, people passing by in their daily life, and they might think that that's odd, or they might be concerned about somebody, but they really don't pick up that this is somebody that's suicidal. So if you think somebody's suicidal, chances are that they maybe have already thought about it themselves. And so if you ask them, and if they're not suicidal, they say no. There's no harm in asking. And in actuality, if you ask them and they say no, but at least then they know that you are somebody that they can come and talk to about suicide. Because there's, like I said earlier, there's a huge stigma around suicide and mental health and depression. And so just by asking them really gives them permission to open up and talk to people. And actually, I kind of covered this. It doesn't give somebody the thought of suicide. And sometimes people think, oh, they're just trying to get attention by talking about suicide. And that may very well be, but it doesn't mean that you should not take them seriously. And the final thing on here, no suicide contracts. I know some people or some counselors have used these in the past, but that's probably not the best thing to do, because maybe it's more to protect themselves. If a safety plan would actually be better, talk about not what they're not going to do, because it's not realistic probably for them to say, no, I won't think about suicide, but to say, well, if you do think about suicide, what will you do? Contact this person, call them, go to the doctor, and just have some plan in place so that focus on what they will do if they're thinking of suicide. And then real quick, go through some of the warning signs. The major warning signs, of course, would be somebody that's actually showing some kind of or communicating ideation of suicide. They're actually talking about suicide, threatening to kill themselves. They start trying to access, firearm, bullets, pills, or whatever. Writing about suicide, especially if it's out of the ordinary. And then some of the additional warning signs would be, here's a whole list, but hopelessness, as we mentioned earlier, is kind of a major one that comes up in a lot of suicide attempts. People can go through terrible situations, but if they're hopeless that things are never going to get any better, that kind of destroys the will to go on. And so just by having hope that things will get better one day makes a big difference. And actually, I guess to back up just real quick, this list comes from the American Association of Suicidology and is included on this card. It was actually put together by an expert. I apologize. But the American Association of Suicidology gathered a group of experts a few years ago to look at the major warning signs for suicide, because there's on the internet there's thousands of websites about suicide, and they found hundreds of different warning signs. I know some of the ones they had listed were, if you call your grandparents, that might be a warning sign for suicide. And so there were some that they didn't really have any evidence to back up. And so what they did is they really looked at the evidence and found the top warning signs. And so this is a great list, this and the previous slide, with the signs of acute risk. But so after you ask them, are you thinking about suicide, and you think they actually might harm themselves, let them know that you're going to get help for them. I think this next slide shows you some of the places that you can call for them, or you can give to them to call. But there's the National Suicide Prevention Lifeline, which actually connects people to a local crisis center near them. The Department of Mental Health has the Access Crisis Intervention hotlines around the state, and that there's a map and a list of hotline numbers online there. And there's also some other hotlines that we have listed on the DMH website. There's pretty much a hotline for every group. There's, if you're a veteran, if you're a cop, if you're a kid. There's a national friendship line for the elderly, just to have somebody to talk to. So there's a long list of hotlines. And some people would never call a hotline. Other people would rather talk to somebody that they don't know. And so they can be very useful. And then where might you send somebody to get help? DMH has a Missouri Network of Care website, which will show you, you can put in your county and it'll show you the available services in that area. The United Way came up with the 211 Missouri website. There's a phone number and a website where you can look up available services in your area. SAMHSA has two great locators for mental health services and for substance abuse treatment facilities that are nationwide if somebody's in another area of the country. And then something else that I wanted to be sure to talk about is lethal means counseling. And if anybody was at our conference last July in Jefferson City, we heard Catherine Barber from Harvard come and speak about lethal means, and she did a great presentation. And the means matter website, part of the Harvard website, it's meansmatter.org. They have some great information about lethal means counseling. But basically, it's just assessing whether a person at risk has access to a firearm or other lethal means, and then working with them or their family to reduce, limit that access. And that seems obvious, I would think, but it turns out that unfortunately it doesn't happen a lot in a lot of cases. And so it's actually listed as a best practice in the best practice registry system on the SPRC website for emergency room personnel. If somebody comes in, I'll show a slide here in just a second about that. This right here looks at same-day crisis. Earlier we looked at the National Violent Death Reporting System, and it showed how many people had a crisis within the past 2 weeks. This study looked at the different age groups and how many had a crisis that day. And the youth, 18 or younger, had 35% had a crisis that day, whether they got into an argument with their parents, they broke up with their boyfriend or girlfriend, had something go on at home or in school in their life that kind of triggered them to attempt that day. And this is another study that was done. This is I find it kind of alarming. They interviewed, I think, 153 men and women under the age of 34, I think in Houston, around Houston, that had survived a nearly lethal suicide attempt, and asked them how much time had passed from when they decided that they were going to attempt and when they actually attempted. And 24% said under 5 minutes. I think 71% was less than an hour. So for young people especially, you really have, like I said, it's important to reduce their access to lethal means, because if it's available, if they have access to a gun or another lethal means, then they're more likely to attempt. If usually a crisis only lasts a certain period of time. So if you limit that access, it doesn't mean that you have to get rid of your guns entirely or take away a car forever. But if you can get them through that suicidal crisis, obviously can save lives. And this is a graph on I mentioned earlier, the emergency room best practice. They did a study looking at if they actually trained parents when they brought in somebody that had just attempted, if their child had just attempted suicide, and they talked to them about going home, limiting access. So the blue shows trained parents, where they actually told them go home, and limit access. The red is untrained parents, and still you don't have 100%, but you have 75% of parents would go home and get rid of the prescribed medication. Lots of people have kind of a stockpile, the medicine cabinet of old medications that's not used. And I know there's some communities around the country, I think even here in Missouri, that actually have a kind of get rid. It's not like recycling, but it's instead of flushing it down the toilet or throwing it in the trash, actually taking, and somebody will dispose of medications for you. Putting alcohol, locking it up. Firearms, 63% of trained parents limited access, where 0% of the untrained parents. And I've heard stories where children have talked about they're suicidal, and when they actually end up dying by suicide, it was with a loaded gun that their parents kept in their bedroom. So even after telling them, or them being aware that their child was suicidal, they didn't restrict access. And has been, I think, let me see, this next slide shows the rates of youth suicide over about a 16-year period in Missouri for ages 10 to 24. And you'll see suffocation has gone up slightly, but firearms has dropped significantly. So I think people are making a difference and limiting access to youth. And what you'll notice is that even though the suffocation has gone up, it's not up anywhere near, it hasn't equaled or gone above the firearms. So I think limiting access can make a difference. There's the study that's done on the Golden Gate Bridge. They've interviewed people that have jumped off the Golden Gate Bridge, and we had a speaker a couple years ago, John Kevin Hines, who jumped off the Golden Gate Bridge and survived. Most people, die instantly or pretty quickly. And I think he's one of about 28 people that have survived. And he mentioned as soon as he left the railing, he changed his mind, wanted to live. He had about 4 seconds, and he was, fortunate enough. I think he broke his back when he hit the water, but rescuers got out there and got him, and he lived. And most people that jump off that bridge anyway don't have a chance. And there's been a big debate recently about whether to put up a barrier, a net, or something. And a lot of people don't want to spend the money. They say that they'll just find some place else. And there's been over 1,000 people that have jumped off that bridge and died since it's been built. But they've done follow-up surveys with people that they've stopped from jumping. About 5 years later, follow-up surveys, and found that I think only like 5 to 10% of them had gone on to die by suicide. So some will, unfortunately, but the vast majority of them will not. So it's not true that if you block one method, they'll just find another one. It has to do really with the timing and just getting it out of their hands at the right time. I talked about a few of the resources that are available real quick, either online or around the state. And I mentioned the Suicide Prevention Resource Center earlier. They have a great feature on their website that has customized information that you can download and print off based on what role that you play, whether you're a college student, you're a media, you're a nurse, teachers. There's lots of different ones up there, and they're adding more over time. So that is a great resource that I would highly recommend. Something that the National Strategy for Suicide Prevention recommends is training for gatekeepers. And a gatekeeper really is anybody that might come in contact with somebody that's possibly suicidal. And I think that's really any of us, whether it's at work, at home, school, church, anywhere. And you can spot other people that may be suicidal. And here in Missouri, we've been fortunate to have 2 youth suicide prevention grants from SAMHSA, one of the handful of states that have received a second one. And so we've received that last year. In 2009, we've expanded the number of resource centers that we have around the state from 7 to 14, and they provide free gatekeeper training to any organization that's interested, schools, businesses, churches, any group. And most of those are free. There are a few that's some of the longer 2-day trainings or something that have a small fee involved sometimes. But most of those services are free. So you can find a list of, in a map. Actually, here's the map right there, but you can find a list of the resource centers in your area if you visit the website, and they'll be happy to help you set up a training. One of the most common ones that is used is the QPR program, which takes about 60 minutes to 90 minutes. It's very quick. A lot of times it can be done over a lunch hour, kind of a lunch and learn type thing. And it's also great to include, if there's time, to include role plays. As I mentioned earlier, some people think that just mentioning the word suicide will give people the thought of attempting suicide. And so even though I know most people hate role plays, the thing that we found for most of the suicide prevention training is that having people sit down with someone and do a role play and ask them, are they thinking about suicide? It's very difficult for some people, and until you sit down and actually do that, it's a great. I think it's a great benefit, because some people kind of beat around the bush and not really come out and ask them. And I think you have to be direct, because if you say, are you thinking about maybe hurting yourself? Some people could think, what I'm going to do is it's going to end the pain. It's not going to hurt. It's going to stop the pain. So just asking somebody right out, are you thinking of suicide, is very beneficial, and that's what QPR teaches. This is a little bit of some of the results of the gatekeeper training. It's used across Missouri and throughout the nation. So it's a great training, especially if you have a pyramid of everybody on the bottom really could benefit from some suicide prevention training. So anybody in an organization can spend an hour to go through the QPR training. There's some other longer trainings available for people that are interested or have the time. Safe Talk is a great one offered by LivingWorks. It's about 3 hours. And then we have the Assist program, which is a 2-day training. and they do actually offer a lot of those here in the St. Louis area, but they're available around the state as well. Both great trainings. And then talk a little bit more about what we've done here in Missouri. In 2003, there was legislation to create a state plan, and that was created, and it's actually dated 2005 through 2010. And so one of the things that we'll be doing in the near future, in early part of next year, we'll be having town hall meetings held around the state, similar to ones that were held 5 years ago when they were working on the plan. And we'll be looking for feedback on how to improve or update and revise the state plan throughout next year. And so that's something that will be coming soon, and there will be announcements made about the locations of where those will be, and people will also be able to submit suggestions online. In addition, on the website, the DMH website, there's also an online calendar of events. We host an annual conference. We have held our fourth one this past July with a great turnout, and there's various, there's Suicide Prevention Week in September. There's various walks that's held around the state. So there's various trainings and events that are listed on there. There's also, as I mentioned earlier, a list of hotlines, some links to statistics. There's a listserv that we have. We have about 700-800 people on, I think, and that sends out a lot of announcements. You can sign up for that and be notified of future trainings. I also wanted to quickly mention that we have our annual conference, the 5th annual conference coming up. It's been set for July 29th in Jeff City, and we're happy to have Dr. David Jobs there, who some of you might know. And that will be followed by a half day of workshops on Friday morning, July 30th. And there's a few things that I don't have on the slides, but I wanted to mention. There's a lot of states have memory quilts for people that have died by suicide, and there's actually some people here in St. Louis have been collecting photos recently, and we're going to be collecting photos from around the state from people that have a loved one that have died by suicide to make quilts that will be displayed at our future conferences and other events. And so that information will be posted on the listserv soon as well. So if anybody, like I said, if anybody knows of, have friends or family that they'd like to see honored on the memory quilt, be watching for that information. And let me see, I think that's, I went through those quicker than I thought, but real quick, some of the things, like I had nearly 60 slides, so I didn't put all these on there, but there's lots of information that we send out through the listserv that's free resources available online, whether it's free online training. There's sometimes it's targeting different groups. There's some CDs that the American Association of Suicidology put out recently for psychiatrists. We have copies of those available that we can share with people. The SPRC website has a great deal of information. They have some posters that were released a year or two ago for nurses in emergency rooms, posters and brochures that talk about people coming into the emergency room. I think on the poster it says 1 out of every 10 people that come into the emergency room probably have had thoughts of suicide and just right before their visit. So people might not always expect somebody to come in with an injury or whatever that they're suicidal, but there's something to think about. And so there's lots of valuable resources online, and we're actually working to put a list of some of those on our website. But the listserv is a great way to access that information and find out about those as they're released. Any questions?
I'd also like to encourage people, if they'd have any questions, to send them in via using the question for speaker link underneath the video window, and we'll ask them on your behalf. Are there questions with us here in the room?
One of the factors that you didn't mention, but I'm sure you run across, but is like suicide as an act of anger or getting even with the people. Like,
yeah.
Let's just take the situation of a divorce coming up and one partner getting someone else, falling in love with someone else, and then the other person feeling a lack of control of how to hurt them, and it's like the final statement of I'll make them pay. I'll make them for the rest of their life know what they did. I mean, I even get sad when I'm speaking of this, but how often do you think that that's an element?
Well, it's certainly, a factor. And I think, let me see, I think you mentioned on the, and I don't think I pointed it out, but anger, uncontrolled anger or seeking revenge is one of the number one, or the top 10 or 12 warning signs that they have listed. So it does happen. Matter of fact, that's something that comes up if, when you're talking to somebody that's suicidal, it's a good idea to try to connect with them and find out what's going on, the good things and the bad things in their life. Sometimes you might think, you might like, so what about your family? What would your family do if you killed yourself? Well, it might be in a situation like that they're wanting to, it's revenge, they're wanting to get back maybe at a family member. And so, suggesting to them, what would you do to your family might be the wrong thing to say. And so that's why it's kind of important to talk to people and find out, what the reasons for wanting to die are before you get into, actually trying to save them and looking for reasons to live. But revenge is, unfortunately, certainly is a factor. Occasionally we hear in the news, those are usually the big news items that come up when somebody, actually, it's like a murder-suicide, kills not only themselves but others. Fortunately, that happens in a very small number, less than 5%, I think, of all suicides. But so we hear a lot about those. It doesn't happen as often as suicides in general. But that's, I think, revenge would be, and anger would certainly be a factor in those cases.
That made me think that in a murder-suicide, there might be an element of redemption, thinking, well, it's terrible that people will hate me for taking the life of my wife or husband and children, but if I kill myself too, maybe people will feel sorry for me, or they won't see me as bad, I won't be as guilty. But also, I appreciate your comments very much about anger and resentment, but I was thinking of a patient I had at Farmington, and he was very, very angry at his company and had a legal battle with them, wanting them to pay for what he thought was disabilities he sustained on his job. And ironically, and sadly, he ended up committing suicide, but he committed suicide after he won the settlement.
Oh, wow.
So at the most surprising time, because when he got his settlement, then he would be able to live at a higher functioning level, get a new car, and all these good things that he needed. But I think in his mind, he reached his goal, which was to win. And it wasn't just the monetary thing that he wanted. He wanted the goal. Yeah.
And actually that kind of brings up, not quite the same, but kind of a somewhat related issue. Sometimes when people are really depressed and down, and then they start, they seem to got over whatever it was, they're getting better, and you think, oh, they're past the suicide crisis. In some cases, it might be that they were so down and depressed that they didn't have the energy to do anything, and in their mind they've made up their decision that they're going to kill themselves, and that will solve their problems. And so suddenly, they appear happier when in fact they've already made the decision to attempt suicide. And then one other thing I wanted to mention too, as far as murder-suicide, something that comes up too. Somebody recently mentioned to me that they thought people that attempt suicide, that's the most selfish thing anybody could do. And what I actually, how I responded to them was that somebody that's, well, actually, Dr. Ed Schneidman from the American Association of Suicidology, I think, once said that, don't ever, I'm going to get the quote wrong, but you don't want to commit suicide, or don't want to attempt suicide when you're depressed, or I forget something. The idea was that you're doing your worst thinking at those times, and that you don't want to actually end your life at that time. You want, because you do really have blinders on. And so I know a lot of people that have thought about suicide. They actually think that it's not going to, they're a burden, that they are a burden to their family or friends or society in general, and that by killing themselves, that people might be upset for a few weeks, but they'll get over it and they'll be much better off. And so it's, to their mind, they're not being selfish. They're actually, they've kind of twisted into where they're actually helping others, and that's kind of sad. In some murder-suicides, somebody might lose a job, and these are probably they're all sad cases, but for somebody to kill their kids and their spouse and then kill themselves because they think things are not going to get any better, but instead of just taking their own life, they kill their whole family. That's that's some very sad circumstances.
Scott, one of your slides showed suffocation, suicides. Are those predominantly hanging? Offhand, I don't know the percentage. It'd be probably the two biggest ones would be hanging or like asphyxiation with the car. Okay.
Like that's actually fairly common as well.
And that's scored as suffocation.
Mm-hmm.
I didn't know that.
Yep.
And the other question I had was I guess that there are sites on the internet where people can go and get support if they're suicidal, and that's a wonderful thing. But there are also sites that tell young people how to commit suicide and make recommendations about methods and ways. And I was wondering if you think the overall net effect is positive or negative?
That is a good question. There was an unfortunate incident, actually I think earlier this year, where somebody actually killed themselves online while other people watched, and some people thought he was joking, and it wasn't until so much time had passed that people made calls and they tried to find him that it was too late. And I remember at the time somebody mentioning that anything in society, good or bad, is going to happen online, and so you kind of have to take the good with or the bad with the good. There's a large number of I think very helpful websites out there. There's a lot of support groups for survivors of suicide, and there's more and more of that done online because people are kind of spread out, and especially rural areas. They can't necessarily travel several counties to go to a support group, and so the internet has been a great support there. The Lifeline, which also operates the Veterans Hotline, now has an online chat for veterans. It's not counseling, but it's a place for people to go online 24 hours, 7 days a week, and talk to somebody there at the Veterans Hotline about what they're going through or where to get help. And so I think more and more there are ways where it's being used for good purposes, but unfortunately there are some websites that encourage it or are not. Don't provide the best help.
We've had a couple of questions come in online as well. Any specific interventions for those who have active substance abuse or addiction problems and are drunk or high at the time of the suicidal threat, or are just continuing to drink or use substances?
See, that's a good question. One of the things I don't know if I can go back to the slide now, but one of the National Violent Death Reporting System, one of the things that it found was the percentage of people that actually had drug or alcohol in their system at the time. And it wasn't as high as maybe some people have thought in the past, but it certainly is an issue. Some people deal with their problems that way and find it easier to attempt if they're under the influence of drugs or alcohol. And something else that I didn't really cover, but actually for your own safety, most people are only wanting to end their own life. But as we talked earlier about some murder suicides, some people, like the suicide by cop, they might not actually be intending to harm other people, but they do get other people involved. And so you certainly have to be careful in situations if you think people might be not only at risk of hurting themselves, but you as well, other people around you. And in that case, I would, you probably, maybe it's one of your last resorts, you want to start off by doing this, but calling 911 is certainly an option in having police involved. If somebody's immediately suicidal and they don't seem to be willing to go with you or to get help.
A couple more. Do you have any statistics or information on suicide by cops, since you mentioned 911?
Actually, I don't, off the top of my head, have any statistics on that. There are some books. Actually, I think the MIMH library has a book on suicide by cop, and that's actually a resource. I didn't mention that, but the MIMH library does have a large number of DVDs and materials on suicide. And not to get too far off topic, but we also we have a mini award program, which we've done about 100 mini awards around the state to small community organizations to do projects and local projects. And one of the awards was to the Parent Link group at MU, and they now have a collection of resources available for parents and family members that people can borrow online from around the state. But getting back to your question, I honestly don't have a lot of information about that. Unfortunately, it is a problem, and something that I don't think, once again, people that are suicidal, they're not necessarily wanting to harm other people, but they're so focused on, kind of their own pain that it can actually, I think, do a lot of damage, hurt to other people who get involved, whether it's people that, some people go out on a train track and get hit by the train, go out onto the highway, involve other people somehow in that, and those people feel, it's not uncommon for those people to feel responsible, like entirely get out of that profession, or even maybe harm themselves later on because they feel so responsible for taking that life, and it wasn't, there was nothing they could have done. But so I don't know if that really answered the question, but there are actually groups for. This is something else that, as far as suicide by cop, something that's not thought of, but there's some groups for cops themselves, because they do have, it's a very stressful job. They have access, of course, to weapons. They deal with, and it's somebody, if you deal with a gun every day, you have easy access to it. Hopefully, you wouldn't use that to solve your problems, but suicide among law enforcement officers is also. I don't know if they have a greater rate necessarily than the general population, but law enforcement made up is predominantly males, and males in general have a higher rate of suicide. So.
Another woman says she understands that families of victims of suicide need memorials, but advertising creating a quilt for those who have committed suicide, does that not glorify suicide for those who feel they want someone to notice them?
That's a very good point. Because you do definitely have to be careful about how you any kind of memorials for somebody that's died by suicide. In schools, sometimes heard stories about schools that want, people will do T-shirts and they'll have some kind of, something up on the wall, and they'll do something in honor of the person that, the student that died, and that's not a good idea. In general, it's advised that they not do anything different than they would for any other student that died by any other cause, because that is definitely an issue that you want. It's kind of, you have to walk a fine line. And that's also like in the news, in the media, if you have a celebrity that dies by suicide, and a lot of coverage of that death. I know there's been studies that showed like after Marilyn Monroe died, the rate of overdoses did increased. So there are things that you have to be careful of, and I don't know, I might not have presented the quilt idea exactly right, but the idea is not to glorify somebody that's died by suicide or their death, but the memory of the person in general, and not how they died.
Have you heard of the book by Jay Asher called 13 Reasons Why? And if so, what are your thoughts on it? She understands that there was a recent suicide in her area where blame is being placed on that book.
I have heard of it, and honestly, I don't know enough about the book itself to comment. I apologize.
And how many people use suicide notes?
Not as many as I think people commonly believe. I've heard secondhand, I don't know if this is true, but I've heard that there's some coroners or medical examiners that will not rule a death a suicide unless there is a note. Unfortunately, a lot of studies have shown, I think like maybe 40% at the most leave a suicide note. So just because somebody did not leave a note doesn't mean necessarily it wasn't a suicide. And there's lots of factors as far as it's up to the coroner or the medical examiner to rule the death as an accident or suicide, and they go with the best information. But there's always sometimes other factors that play into it, whether it's insurance. Here in Missouri, a year or two ago, they changed actually the law to where it used to be if you have a life insurance policy and you die by suicide, that they have to pay out unless they can prove that you were planning suicide at the time you signed the policy. And they changed that. A lot of states actually have like a 2-year time frame where within 2 years after you sign the policy, if you died, they don't have to pay out. And Missouri set it up to, they passed a law to make it within 1 year of that. But I found when that was about that same time, I found a study that looked at the rate of suicide and insurance policies, and it found that after people signed insurance policies, the rate of suicide did drop, but the rate of accidents increased, and then after a year or two, it kind of balanced back out. So I think people maybe do a better job of disguising a suicide to make it look like an accident if they think that that it might not pay out as far as the insurance. So you can look at that as some people looked at the law as a protective factor that would prevent suicides, but that's kind of questionable.
Couple more questions, Scott. Sure. This is absolutely fascinating. Some years ago, the FDA was concerned about a relationship between antidepressant medication and suicide, especially in young people, and so they required a warning on the box. And as a result of that warning, the number of family physicians and general practitioners and family doctors prescribing antidepressants to teenagers went down precipitously. And almost at the same time, the number of youth suicides started to go up. And do you know if the current thinking is that antidepressants are underprescribed among young people because of exaggerated concerns about suicide risk?
I think after that was big in the news, the black box warning, there was a drop in whether it was doctors or maybe parents also did not want their children taking antidepressants, and I think that probably it probably did somehow factor into the increase in youth suicides. I think from what I've heard, antidepressants only, as far as youth, they have a greater risk of maybe increased suicide than adults do, but it's only for a small number of youth. And so I think maybe the biggest problem with antidepressants is that they certainly do help people, and maybe a combination of counseling and antidepressants would be the best solution. But I'm afraid some doctors, as maybe like a quick fix, give the prescription, and then that's it. And I think what's really necessary is fairly regular follow-up with not just youth but adults as well, but to make sure that they are doing okay, and that see if it needs to be adjusted. And I don't think I know doctors are always busy. I'm not trying to lay all the blame on them, but prescribing antidepressants, I think, is something that does require a certain amount of follow-up with patients.
Thank you. And I guess that in the United States, there are about 100 suicide deaths among physicians every year, about the size of the typical graduating class at Mizzou in our medical school. And I've never seen data on this, but I've always heard that the incidence of suicide was especially high among surgeons and psychiatrists, and that it was very low among pediatricians. And I've also heard that dentists had a very high rate. And I was wondering if you've seen data on that.
I have on some of those, not all of them. I know, actually, I was just looking at the dentist one recently, and it's because there's actually a lot of, over time I've heard some things like, this profession has the highest suicide rate of any profession. And so I don't think that's, any of those claims are true just because there haven't been studies on every profession. But there are certainly some professions that have higher rates than others. And dentists, I know, are one of them. It's predominantly a male profession. They live, or not live, but they practice. They tend to practice longer, I think, than physicians. And so, older males have higher rates of suicide, and so there's lots of things that factor into that. It's kind of like the military and veteran status. More and more women are entering the military, but so it's kind of hard to factor in the fact that what the division is of male and female in any profession, and what other factors are involved. But there are some professions that they've showed that have either a higher or lower rate of suicide than the general population.
Well, Scott, you drew a wonderful array of questions from all over the state and around the country, so did a great job with today's topic, so thanks for being here with us.
Thank you.
Our next program is going to be on the 16th. The time is a little bit different, so check the website. We'll have Dr. Clay Anderson doing a program on grief. I guess that sort of follows the suicide topic fairly well. And that will be originating once again from the University of Missouri at Columbia. We've been trying to work out our technical difficulties with them, so hopefully we'll do a better job in presenting that one to you this time than we did last time. In the meantime, we'll keep the CEU link open on the website and send it to you in a follow-up email. We'll also collect some of those references that Scott gave us and include those in the follow-up email. You'll probably get that either later this afternoon or tomorrow morning. And we thank you for your time and attention this afternoon. And Scott, we thank you for your time and your expertise.
Thank you.
Thank you.